the table of content. We will discuss or share this information. Of course, introduction will be there, 5 key components, classification and terminology, site associated with pressure-induced injury, stages of the pressure source, clinical evaluation, infection on pressure injury, summary and recommendation, safety prevention measurement that Nonotuck team can support, general approach for prevention, and other additional note related to pressure injury. All right, so we start with the introduction. That's just the picture of the layers of our skin. Keeping the member safe from pressure injury with prompt, proper care and thorough follow-up in their healing process will help reduce complication and improve their quality of life. Okay, is the top is little bit distract me, so I prefer Rob to see just the slide. Thank you. Pressure-induced skin and soft tissue injuries are localized areas of damage to the skin and or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shears. This is as you know and familiar when you take care the members with issue in mobility or limited in their dependence to their independence to do their daily activity because of immobility issue. Usually the area is on this area like sacrum, posterior pelvic floor area, heel bone area, and ischium area. The superficial skin is less susceptible to pressure-induced damage than deeper tissue. The external appearance may underestimate the extent of the damage. So we have to put this really into our consideration. Lesions are typically related to immobility, as I mentioned, members with significant mobility, ambulation, members that need a wheelchair to ambulate. Medical equipment or devices that can contribute to pressure injury. The skin lesion can also result from poorly fitting casts or other medical equipment or devices. These supportive devices can cause mucosal pressure injury. Some of our members have ankle foot orthosis, mattresses, wheelchair, traction devices, splint, braces, casts with or without diabetes, and other peripheral vascularization issues that can increase the risk of their skin integrity. Pressure ulcer occur in feet of member with severe neuropathy and or vascular insufficiency, often due to diabetes. Many of the members we support have this condition in their diagnosis list. This is the some of the safety supportive and medical devices. As you know, I like pictures, so I put that in here. We can go to the next slide. This is other pictures, and this is common devices that may cause injury, increase the risk factor for injury: feeding tubes, oxygen delivery tubes, IV catheters, Foley catheters, orthopedic devices, restraint. Negative pressure wound therapy or vacuum-assisted wound closure refers to wound dressing system that continuously or intermittently apply subatmospheric pressure to the system which provide positive pressure to the surface of the wound. Sometimes the dog would like to do this approach, and this also can increase the risk for injury for sure. Bedpans, abdominal binders. Some of our members have these abdominal binders to keep that tube in place. ID bands also can cause these braces and casts. Five key components related to pressure injury or skin. Start with S, that's from the skin, yes? So S is surface. Signs to look for when doing a skin inspection include painful areas. Even though the member probably won't say that this is pain, but by looking on the area, we can tell if that is painful or not. But of course, it is depends. So just want to clarify if that some nerve area are already damaged, probably then the member cannot feel this pain anymore. But that the area is just so scary to look at. Red, purple, or blue skin, blister, swelling, dry patches, shiny areas, warm areas that we have to look at. Hey, keep moving. Move, change your position frequently when in bed or sitting in a chair to reduce or relieve pressure. I is incontinence. Members with incontinence, as you know, are at a higher risk to develop skin integrity issue. Incontinence increased risk for all pressure ulcer, but especially on the full thickness injury. Full thickness injury is this burn extend through and destroy all layers of the dermis and often injure the underlying subcutaneous tissue. And nutrition and hydration. Once a pressure injury has developed, nutrition and hydration play a vital role in wound healing. At each stage of the wound healing process, the body will need a balance of nutrients. This includes more protein and energy or calories together with vitamins, minerals, and fluid. And as I had mentioned in um, our previous presentation, I think we can always do this approach through the nutrition. Daily intake is very important. The most common anatomical location of medical devices related pressure injury include ears, nose, face, chin, and lips. The most common grading of MDRPIs were grade state 1 or grade 2 injuries. And also, I already mentioned in the prior slide, the most common medical devices that can cause MDRPIs include immobilizing devices. You see the pictures, face mask, endotracheal devices, nasal cannulas, and nasogastric tubing. Important documentation logs form for skin integrity and supportive protective devices. This is from Kitty, so that's why I put that her name there. I do hope I put that statement correctly. Independent is not always the greatest for prevention. We can miss the opportunity for the assessment. Sometime when we think that the member that or the person served are very independent and very personal, sometimes we can miss this opportunity to do the thorough assessment because we think like, okay, so the member can check themselves and will report their concern or whatever that occurred to them to their provider or sharegiver. But unfortunately, this is not always the case. So that's why I put that statement there. Important factors to observe, assess, document, follow up, and intervene with the care and support. Member with supportive protective devices. Is the member independent or physically dependent for care and treatment? If members are independent, can they be willing to let the team or a consultant RN do a hands-on assessment? I put this on quote, hands-on assessment, because the nurses, we are not do this hands-on. However, please use our common sense, right? So, we can actually, I will elaborate more about this. Is there any restrictive devices, such as the orthopedic devices and everything else that I have mentioned on the other slides? Is there any VNA support? So this is the thing that we need to think through and put uh, on our documentation, and we need to follow up. Okay, so we continue. The supportive devices form need to be completed. I believe that you have this form, right? Especially for DDS, ABI, MFP. These supportive devices forms need to be completed and based on the uh, prescription or evaluation that have been done for the member that we support. Can be from their PCP, can be from OT, PT, or something if related with respiratory or allergy issue, can be from their allergies, can be from their uh, res, uh, respiratory specialist for CPAP, can be from their GI if the member has G2 or some other medical safety supportive devices. Skin integrity daily check is need to be put in place. We need to review it weekly or monthly or sooner with the team for any question or concern. So I just would like to put this as a kind reminder. If the member has some certain diagnosis that can increase the risk for skin integrity issue, such as diabetes, neuropathy, and also gait imbalance or gait issue. And if you or your team already put this safety protocol, or for example, you create such a great individualized training and safety protocol, um, you did kind of like additional training. However, if you do not put the skin integrity logs in place, we cannot have the good documentation. Because if something happened, even though we can say, oh, well, the training has been done, we have this safety protocol in place, and we told the caregiver to make sure to check the members 3 times a day, uh, report it to us. However, when during the home visit or something happened, I don't know, maybe the member just like refused to be checked and cannot, just doesn't want to cooperate with the shared living provider, this can cause issue. So please make sure we have those documents. So on the documentation, it can show to us, okay, so the shared living provider did a skin check 2 or twice a day. There is initial there is documentation, and we put that information as well on our documentation after a home visit. So just to make sure that the documentation is there, because even though we have training done, we have a safety protocol put in place, without the follow-up um, or documentation, I think something missing in this path. Okay, so make sure that if you have those, then you should put some type of logs or daily check. I put that in here. The team can also create a specific individualized skin check with specific training. This is the form that we have that the Kiwi have this on the server. So you're very familiar with this form. I would also share with you some other form that the other nurse has shared with me. So on the other slide, please. So this is just an example of something that you can create with, of course, the picture. So for example, you have the members diagnosis. What is the diagnosis? The stage. I put this still have the Harrington Hospital. This is from one of the member who had care, who received the care from this hospital. Current support. What is the current support? If the current support is like a VNA, then put in there and explain. Visit the home 3 times per week. When this support happen, what dates? So we can create this. Um, and I put that blank there. Will be assessing wound and revising treatment on a regular basis. Visit can be once a week or every other week. And is there any medication, pain management that prescribed for this member? If the member has this prescribed to her or him, please put those medication. And what is the concern? So if you have that concern, if have any other concern, then put any other concern. So this is I think I mistyped. So if you have a concern or other information or other notes, you can put that. It's just a thought. So you can create uh, based on the members' needs. Next slide. So this is just the picture. Is for example, the member has really, stage 2 on their buttocks. So we can put the picture, specific picture, and then we can do the follow up specifically on that area. And so I put this wound location. We can do the what is the color or drainage. The caregiver can do this. We need to train them in addition of the VNA if the VNA put in place. Usually for something significant like this, we can reach out or have, like, for example, the member was admitted and then was discharged, but we feel that this skin integrity issue will be continuing at home. So then we need to reach out for other extra support from the VNA, for example, and then we have this training done for the share living provider to make sure that there will be no gap after the discharge. So that will be complete healing for the member. So just I put this pain, like, is there any pain? What is the scale 1 to 10? This is just an example. So next slide, please. This is the example that I received also from another nurse. I guess I can say it right. This is I believe this is Jessica Wicks make this. And the previous one I think is from Adjoa. So this one is very small, but this is the also the example for the skin breakdown protocol. So you can put the name, of course, date of birth, date of the implementation. I put that additional health background, so you will know what is the condition or the situation. And then we can put the implementation. What is the support that your team has been given to this member? Uh, so there is some other a note in there, and of course the physician signature, share living provider, and respite provider if applicable. So um, Next slide.
Can I
We
just
go
can I just
to
interject for 1 second? Somebody said they couldn't see the slides, Surfy, but I think I can, and can everybody else see them? Maybe it's just your view at the top. You might want to
oh,
change your view. Whoever can't see the slides, I could see them, so I just wanted to.
okay. All right.
Is that
Thank you for letting me know.
okay?
I hope they can see it now. All right. Classification and terminology. The National Pressure Injury Advisory Panel made change to its classification in April 2016 and suggested using the terminology pressure injury instead of pressure ulcer to describe these types of wounds. This term used to recognize that the lesser damage due to pressure may not be associated with skin ulceration and that deep tissue pressure injury can occur without overlying skin infection. Next slide. This is the staging. I just do it quick. So staging of pressure injured skin and soft tissue injury. Stage 1, skin intact but with non-blanchable redness for more than an hour after relief of pressure. Stage 2, blister or other breaks in the dermis with partial thickness loss of the dermis with or without infection. Stage 3, full thickness tissue loss, subcutaneous fat may be visible. Destruction extends into the muscle with or without infection. Undermining and tunneling may be present. Next slide. Okay, this is stage 4. Full thickness skin loss with involvement of bone, tendon, or joint with or without infection. Often includes undermining and tunneling. Unstageable. Full thickness tissue loss in which the base of the ulcer is covered by slough and or scar in the wound bed. Deep tissue pressure injury, purple or maroon localized area of discolored intact skin or blood-filled blister due to damage of underlying tissue for pressure or shear.
Thank you, Sophie. I just want to, as a reminder, and I think we all know this, our job is not to stage any, you may have said that, our job is not to stage, but this is just for your knowledge. A doctor or a wound ostomy nurse will do this part of the assessment for us. And I think I just want a full disclosure. I do believe Sophie's going to be sharing a photo of an ulcer. So just to let everybody know.
Yeah, thank you, Kitty. Yeah, so this is just like information for all of us. Of course, we not do like Kitty said, we not do stages, but this is information, and then for the nurses as well to help them in their documentation. So like, okay, this is the situation, and we reach out to the PCP or with our concern and question or things like that. So I think this is a good information for us. So yes, so another slide, please. This is the site associated with the pressure-induced injury. So you can see, so then for your information, so I will not elaborate much on this. I think the picture show to us, right? So very clearly. Next slide, please. This is the stages. So you can see the stage 1, 2, 3, and 4. Never underestimate, it starts from the stage 1. Next slide. This is also for your information. So this is clinical evaluation. The management of pressure in the skin and soft tissue injuries begin with a clinical assessment of the wound and a comprehensive assessment of the member's general medical condition and risk factors to identify reversible condition. For Nonotuck team, upon receiving a significant report or concern from share living providers or caregivers, the members' PCP needs to be notified immediately with the identification areas of skin damage. Clinical evaluation. Again, this is also for your information. but at least we know what to see, what to expect with what we see. Uh, so things that should be evaluated are, if applicable, with the member's health status, skin integrity presentation. Is we can see the length, the width, and the depth when we see, right? We not do hands-on. When we do the home visit in person and we look to the person, maybe we can see this. The presence of sinus tract, necrotic tissue, or exudate, evidence for healing, such as the presence of granulation. So this is like, for example, follow up when the member have VNA support and everything, like, um, go smoothly as it was planned on the plan of care. We can start to see this evidence for healings, such as the presence of granulation, and we can put in our documentation after the home visit. If for if for some reason the appointment cannot be made right away, this is the related with the when you see the case. If you have the consent, sometime uh, we can, Kitty, please correct me if I'm wrong. We can took a picture of the wounds that may be helpful, and we can share this with uh, the primary care provider. This not occur often, but it can happen. Like, for example, if the members okay with that, the sharing provider communicate with the team. Unfortunately, the team cannot do right away in person home visit. I do believe the caregiver can take a picture and show to the team. So then the team can have this uh, picture that they can have some internal meeting or some discussion with the case manager who manage the case, with the RN consultant, with their program directors. So if uh, this can be done, so you can take a picture. So this will provide the PCP also with information, so the lesion can be staged. Of course, that can be accurate because it's from the picture. Sometimes it look more scary than in the real life, but just FYI. Next slide, please.
Just to follow up, Sylvia, a dialogue should happen with your program director and QE prior to taking any photos and sharing. Thank you, because there's various areas, and there's just really some risks associated, so benefits and risks. So we would want to have a discussion before people take photos. But thanks for bringing that up because it is very helpful in many
Thank you so
circumstances.
much.
Thank you.
Yes. Thank you, Kitty. Yeah, because in my imagination is probably just a more toward like extremities, but yes, totally agree. And my apologies. I supposed to uh, uh, make this clear more. If the area is very personal, like buttocks or like more like personal area, we have to be very, very considerate and reach out to QE. Hopefully this won't happen. Um, we are responsible and expected to deliver or share accurate data, information to their healthcare provider for any health concerns, issues, so they can get a better understanding. Considering the limitation of the members in expressing their needs, including describing sign and symptom discomfort and pain they have, and also as our support for their caregivers. Next slide. Our care and support can be done through our eyes assessment. Each of the circumstances is unique. The hands-on approach by the Nonotuck RN will be allowed through the recommendation or decision by the wound clinic, physician, healthcare providers, or and management healthcare team that treats the members. We can also get VNA support to care for the members at home. Two-way communication and thorough documentation will need to be put in place for this support. Make sure you communicate closely with the nurse, the VNA support. So again, it's no documentation. It's dangerous. No documentation mean the support or the care is never happen. So we have to make sure, reach out, that we have this documented, we have this in our file in the home book. So this is very important. Next slide. This is just like it seems like redundant, but this is a very important, so that's why I put that back in here. Infection or pressure injury can present with this all these things. So you can read this to make it fast. It's already 56 minutes. So local sign of soft tissue involvement, such as worm, erythema, local tenderness, purulent discharge, and the presence of foul odor. This is all the sign that you can look for infection. Next. This is another staging system. Just for your information, several staging systems have been developed to describe the extent of the pressure-induced injury to the skin. The most commonly used system is from the National Pressure Injury Advisory Panel, NPIAP. So I will not elaborate much about this, just for your information, so you can see. Next slide. So this is just a different thing. So the clinical feature that you can look, like the skin color, the discharge, so it's in there, and the stage is different. Next slide. This is the edema. You can also see with swelling. You can see with your eyes when you do assessment or when you do home visit in person. So this is also FYI. Peripheral tissue induration, that probably this is also just for information, because no need for us to touch and listen. There is, if there is some something in there. Next slide. This is the edema. Also, I'm sure you're familiar, especially the team nurses, with this thing, but I just would like to share this with other other team, clinical, case manager, the case manager, clinician that may be interested to just have this type of information. So I put the picture in here about the edema. Not elaborate much, is in there. So next slide, please. This is continue with the different type of stages. So this is the healing. So you can see the granulation tissue, epithelialization. So just for your information. Next slide. Okay, so just also FYI, the key difference between epithelialization and granulation is the epithelialization is a part of wound healing which form a new epithelial surface on the open wound, while granulation is the process of forming new connective tissue and blood vessel during the wound healing. I put it in here because I believe this is important for the team nurse to share this information, because sometimes the sharing provider can ask, is that really healing, or is that okay to look like that? So okay, anyway, so next slide. This is the picture. So this is you can see that the granulation tissue, for some who don't have this kind of like information or little understanding, this picture can be scary. So we need to be able to explain to the sharing provider if they have some question or concern. Right. So next slide, please. Summary and recommendation, teamwork, we almost done. So number one is always educate, training, refresher. Skin integrity logs will be helpful and much needed for members with diabetes, severe neuropathy, and or vascular insufficiency and mobility issue. Immediate response through thorough follow-up has to be done to question and or concern related to members' skin integrity issue. If the member is hospitalized, please ensure the complete and accurate documentation on the member's skin integrity issue pre and post hospitalization. So this is super important, because we do not want to take all the responsibility when the pressure ulcer stages is just so significant, and they can think like, gee, what is the team has done, or what does the sharing provider do? Why this member has such a severe pressure wounds or injury. What happened? Well, no, because pre-hospitalization, our members go to the hospital with their skin intact. So we need this to document to make sure this is not occur prior to the hospitalization, but this condition could be occurring during the hospitalization. Can happen. Is nobody fault. Sometimes it just occur because our human body, with all this physical stressor, with all the diagnosis, with the lying down in bed, it can cause this pressure, skin pressure injury. Perform daily skin assessment, skin integrity log, and implement measures to maintain skin integrity and prevent skin breakdown. Redistributing pressure is crucial in reducing or preventing pressure injury. Proper positioning, turning, repositioning, pressure relieving support surfaces, and support to minimize tissue pressure should be provided for all members with pressure injuries, particularly those with open wounds. Next slide. The treatment of pressure-induced skin and soft tissue injuries begins with a comprehensive assessment of the member's general medical condition and evaluation of the wound, identify complications of immobility, assess the member for mobility, gait, strength, and motor skill, refer or review members' PTOT evaluation reports, apply knowledge of nursing procedure and psychomotor skills when providing care to a member with immobility, apply and maintain devices used to promote venous return. I put this in here just to clarify this usually this condition, if you see this member condition through their diagnosis, historical medical report, current condition, medical supportive devices they have. We need again to create a more individualized and specific um, forms or training. So just to clarify, why is it apply and maintain devices? Well, if the member, for example, have a stocking to reduce the edema or something like that, this need to be documented as well. So if for example, the caregiver check the member if the stocking is too tight or put in the wrong way. So that's the thing that I believe apply in daily care from the sharing providers to the member. Documentation start when there is a breach of a member's skin integrity and follow up with the member PCP or specialist. Standardized system stages should be used to document the initial presentation. Uh, just to clarify again, this is not our responsibility to make a formal comments or diagnose, but it just use the common sense. If we see and we know this is a stage one, we can uh, uh, sharing our thoughts. It's okay to the uh, primary care doctor. Okay, so this is that our thought. It could be wrong, but it look like it. Because why? Because we have this information, and the information is out there, and it's always great to know something when we care for someone. So at least that we have a base, we have a understanding how we communicate more accurately to the primary care doctor or other specialists. Okay, so if like we think that is stage two, saying that it could be like it. I mean, we not do the diagnosis, but we have this understanding by doing assessment through our eyes and listen to the share living provider report and the members. So follow up with the prescriber PCP recommendation with the members plan treatment, and follow the healing process of the wound, see the staging and healing scales. I put it on red, reach out to the members, PCP specialists for any concern or question, of course. Next slide, please. Uh, General care or safety prevention measurement that Nonotuck team can support. Again, is always referral, advocacy. I just add this recommendation for pain management in controlling pain. We can advocate, we can ask for this. Adequate pain control usually will be given by the physician if there is significant discomfort or infection on the wound site. Local factors that may contributing to pain, such as ischemia, infection, or breakdown of surrounding skin should be reported and documented. The physician usually will pay attention to pain management during wound dressing and debridement. Again, you communicate with the VNA, look at their report, listen to the members, and follow your gut and your heart. We trust each other, everybody professional, but always uh, follow that. You know your feeling when you see when you look the assessment, you feel something wrong. I think the care is need more. I think something need to be reevaluated with the treatment. Uh, Saying this, no worry, just don't worry. I mean, just express your concern and question to the team healthcare. Um, so because you case manager, the consultant nurse, and the sterilizing provider, they are know the members. So I think that's important to communicate your concern and if you have any question. Um, Next slide, please. Uh, Back to the daily intake, assessing and improving, optimizing nutritional status should be assessed, and any identified deficiency should be corrected. You can tell if the member is so fatigued, weak, pale, uh, even constipated. That can cause also, right? And look dry because dehydration. So look, use your assessment and trust yourself. So reach out, request member PCP to refer for nutritionist evaluation. Nutritional intake should be assessed by a nutritionist. An element of this comprehensive assessment may include protein, caloric intake, hydration status, serum albumin or prealbumin, and total lymphocyte count. So if you reach out to your primary care provider, surely the the follow-up care uh, for this member will be more thorough, deeper, because we really would like to make sure that healing process can be done properly. Lab markers by themselves are not sufficient marker of nutritional status. I put that there because that's very important. We need to do the collaborative work. It's not just by the lab markers. Nutritional deficiency should be corrected. If oral intake is not adequate to ensure sufficient calories, protein, vitamins, minerals, nutritional supplementation will be needed to help the members with the recovery process. Of course, this is also our discussion with the other specialists, with the nutritionists, with the PCP. Is always a teamwork, but we have a right as a case manager who manage the case, the nurses, to voice our concern and question, because again we know that some or most of our members, they are not don't have this understanding and be able to fully express their needs. For some of course they can, but there is some limitation, so we need to be there for them to support and help them. Next slide, please. Just additional information. Members with pressure-induced skin and soft tissue injuries often are in a chronic catabolic state, breaking down or losing overall mass, both fat and muscle. That's why the intake is very important. Optimizing both protein and total caloric intake is important, particularly with stage 3 and 4 pressure injuries. And now with this information, you know all the stages from different approach, right? Okay. Next slide, please. Skin integrity safety protocol should be put in place. It is including, not limited to. I will not elaborate much. Everything is in here, similar with another slide, but repositioning is very crucial. So please put this on the safety protocol and step by step. Yes. Next slide, please. Monitoring. This is also part of the assessment. Uh, any possible complication and pain control should be documented as well. Documentation may be facilitated by using one of the scale for healing ulcer sharing and reporting this information with the member's PCP or specialist. This is especially applied to for example, to the member who just discharged from the hospital and then has a significant skin issue. So the documentation need to be thorough and reported to their primary care provider or other specialists. Next slide, please. This is the general approach to prevention. Reduce or eliminate underlying contributing factors. We already mentioned all about the factors. Also, I add in here, provide appropriate psychosocial support. So I mean to say, reach out for consult or request for referral, because sometimes this happen. The extent and magnitude of the psychosocial complication have not been well defined in here, and the psychosocial support is often not considered because somebody who has that really severe skin issue that can and pain that can really interfere with their daily life. So we also please do not miss this psychosocial support if needed. Okay. Next slide, please. Wound management, we can always reach out. Treat the infection. Of course, the infection need to be treated all the time, right? Okay, next slide. Sounds like a running because it's just like already, yeah. So other information related to pressure injuries. So this is also just additional information, but this is important. To date, there are no randomized trial available to identify whether repositioning makes a difference in healing rates or the optimal repositioning regimen. However, though, this is very important still, and please do continue to do this. Okay, it doesn't matter what they said, the repositioning, blah blah, but I personally believe that it will reduce the um, uh, the risk to make the skin get worse. Pressure relieving support surfaces are also helpful in reducing tissue pressure. Support surfaces for pressure ulcer treatment can include specially designed bed, mattresses, mattress overlays, and cushion. We work, I believe, closely with VRNS. Sometimes they have some specific uh, safety supportive devices or medical equipment that we can reach out and discuss with them if they have it and what their suggestion or stuff like that. We can reach out to them. Next slide, please. Almost done. This is again related with the pressure relief, and then I add in here the circulation also is very important, and this one is the circulation to the lower limbs often becomes compromised due to arterial disease such as atherosclerosis. Although associated with also increasing age, poor circulation is seen in younger people. So do not underestimate with somebody like 31 and the other is 72, doesn't matter. We carry our skin is for years, so we have to be kind to our skin. And particularly in association with risk factors such as smoking, diabetes, and hypertension. Okay, so look at this thing. So this is the reference that I use to create this PowerPoint. Next slide, please. And this is just the YouTube. I was playing with the computer and looking. Can we have something that interesting just to watch? And I found some, so I just put that in there. Phew, so all set. 1 hour 15 minutes. I'm sorry. It's just less more than an hour. It's tough because it's so much information that I would like to share, and I'm sorry again. I could not talk it, but I try my best. So I hope that clear enough. If not, you can send me an email. CC Kitty, as always, is teamwork. So I sometimes I feel I can explain better through the email, or you can call me as well. So uh, thank you so much again, everyone who save your time to for attending this presentation and be with me. I really appreciate it.
Thank you, Serbi. This was a very informative, and
Thank
you did a
you.
great job. So
Yeah, thank you so much. I appreciate that. Just so much. Yeah, just reach out to me and Kitty if you have any question, anything for protocol, for individualized training, for some question about why there is so many different forms, which form that we need to be used. And of course, I, I or we always connect very closely to QE department. Is Rob, Grayson, Doug, Angela, and everyone else at the QE department. So we will reach out, and HR, of course. So anyway, so all right, thank you again. Spring is coming, and cannot wait for that to see the flowers blooming. And yeah. Oh, Rob, I think we missed one slide, right? I usually put the pictures. I think I
uh,
did. The last slide after the
oh, we did.
yes.
Yes, we did. Hold on one second. I can
Yes,
share the
I think
screen.
I always put picture because I'm little crazy with pictures. So, but the picture is suiting. I think it's about the plan. Yeah, there you go. That's it. I just want to share those the green trees. All right. Thank you very much again. Bye. Take care. Bye.
Okay, bye.
Bye, thank you.
Thanks.